Well, thank you all for joining. Welcome, everyone. Welcome to our first of the series, EPI-WIN on Health and Meets Peace. Thanks to all of you for joining, especially for those of you who are in places where it's really early in the morning or really late at night. We really appreciate you being here. Today, we'll be talking about WHO's Global Health and Peace Initiative, and we'll have a case study from Cameroon. And we have, to start the show, we have Dr. Altaf Musani, the director of the department, and we also have Mathilde Baudard, technical officer at WHO. And from WHO Cameroon, we have Claver Lotza. Before I hand over the floor to Altaf, a few housekeeping. As you know, for those of you who are familiar with EPI-WIN, please introduce yourself on the chat. We love to know where you come from. And please keep all your comments positive and constructive. No rude comments, please. While we'd love to hear from you in the chat, if you have any questions, please put it in the Q&A box, because if you leave it in the chat, sometimes it gets lost. So we'd love to hear from you. Please do introduce yourself. This webinar is being recorded and it's also being live streamed on YouTube. And the recording and the presentations will be shared with all registrants after the webinar. So don't worry on that score. You will get the presentations and you will get a recording. Without any further ado, over to Dr. Altaf Musani for this very exciting initiative. Welcome, Altaf, and over to you for the opening remarks.
Thank you, Supriya, and welcome to you, and a profound amount of thanks to the EPI-WIN initiative and the platform for hosting us today. Let me start by welcoming all our guests, and I can see in the chat, we're from all over the world. So again, also extending my good morning, good afternoon, and good evening to many of you who decided to join us today. As Supriya said, my name is Altaf. I'm the director of the program here in Geneva that houses the initiative. I'll keep my remarks short so that way we can really dive into the program and really engage the audience in terms of where we'd like to go. And let me start by saying that this is the first, but certainly not the last of our what we call webinar series. This is one of the important flagship activities within the Global Health and Peace Initiative. And colleagues may recall that this is associated with the resolution of the World Health Assembly, particularly 77.9. Which really tasks the Secretariat with raising awareness, having a dialogue as we're doing today, and better understanding some of the dynamics that frontline practitioners are struggling with to advance the public health agenda, no matter where they are. And to that need, now more than ever, we need to raise awareness, particularly as conflict and their environments are becoming even more complex. And this is making your work, our work collectively challenging, taking on higher risks and threats. And we're seeing this in health emergencies all over the world. A lot of lessons and best practices from the Ebola crisis, as well as the Mpox outbreaks in the Democratic Republic of the Congo, tackling cholera in more than 30 countries around the world. And again, a very stark lessons from the global COVID-19 pandemic. What some of these lessons have shown us is that responders such as yourself need to take into consideration local dynamics and the need to build trust so that way health responses are robust enough to really advance that public health agenda. But equally so, to make sure that we protect healthcare workers, first-line responders, particularly at the community level. And to that effect, we know that from our data, some of the largest outbreaks are happening in a lot of the settings where you work in, particularly what we codify as fragile, conflict, and vulnerable situations. We know from these situations, as we're seeing right now in Gaza, as what is also equally unfolding in Lebanon, that health systems are often disrupted. And when we have the collapse of health systems, it has a deep impact on medical supply chains, the availability of healthcare workers, the protection of healthcare workers, and then as a result, as we spoke earlier, in terms of the vulnerability of the public health risk that we see, whether you're in a crowded situation or whether you're fleeing across a border. Hence, even challenging our ability as responders, as humanitarians, as aid workers, to be able to do what we do best. Our Director General has often said that health and peace are two sides of the same coin. You've heard him consistently talk about that there can be no peace without health and there can be no health without peace. So it really challenges us and demands us to rethink our approaches of how we operate in some of these complex environments. And to this effect, today we'll be hearing from our colleagues, how do we make our interventions sensitive to peace and conflict, where appropriate, responsive to and contribute to some of the peace-related outcomes. And then equally so, the Global Health and Peace Initiative focuses on the local level in terms of local peace outcomes, that trust building at community dynamic level, at the societal level, where health objectives and health delivery is valuable but critically needed at all times. This particularly involves designing and implementing health activities in a way that increases social cohesion and what we talked about, trust, and strengthens that community resilience in the effects of armed conflicts or any other form of violence. These, in essence, are sorts of peace-related outcomes that we were referring to. In the current environment and geopolitical situation that we're struggling with, we continue to try and advance the humanitarian agenda, but it demands all of us as humanitarians, which could be United Nations agencies, non-governmental agencies, or community agencies, to address our commitment to peace, but to clarify that the Global Health and Peace Initiative has no ambition to make peace at the political level, but rather contribute to sustaining and preventing conflict, a part of the Secretary General's agenda on sustaining peace. Again, the Global Health and Peace Initiative is really looking at that community dynamic level and really advancing healthcare access, healthcare coverage for those who need it most. My colleague, Mathilde, who is part of our technical program here, will present some of these details about the program. And then, of course, we're very excited to hear a little more ground truth when it comes to what's happening in Cameroon from my colleague who is currently coordinating the Health and Peace Project in the far north region of the country. With that, again, let me welcome all of you to a first of many exciting conversations that we wish to have with you. Please feel free to ask questions, challenge the narrative, and then also participate in helping design activities at that local level. Back to you, Supriya. Thank you. Mathilde, I think we're going to hand over to you to take us further into the Health and Peace Initiative.
Right. Thank you very much, Altaf. And over now to Matilda to lead this session and moderate it. Matilda, over to you. The floor is yours.
Thank you so much, Supriya. Thank you so much, Altaf. Good morning, good afternoon, good evening, everyone. It's a real pleasure being online on this webinar with you today. The first of a long series, an exciting one, we hope, as Altaf just announced. So I'm going to introduce the Global Health and Peace Initiative, providing an overview to all of you. Some of you are probably already familiar with it. For some of you, it might be the first time you are hearing of it. So I hope the presentation is going to meet everybody's expectations. And then I will hand over to Dr. Claver Lotsa-Momo for a case study on a Cameroon project. And then I'll take over and provide a few more hints as to what the Health and Peace Initiative is and is not, and then open the floor for, I hope, a very exciting discussion with you, because this is also the point of this webinar. It's not just to provide sort of top-down information, to feed you with information on how we can link health and peace programming, but also to really discuss that with you, discuss good practices, discuss lessons learned, discuss challenging, and continue improving the initiative based on that open dialogue with practitioners from different countries, different profiles. So let me start. Supriya, I'm grateful if you can start sharing our slides. So the Global Health and Peace Initiative was launched quite recently. It was launched in November 2019. Next slide, please. With the championship of two key member states, namely Oman and Switzerland. And since then, many other member states have joined the initiative and its championship, of course, with the support of the Eastern Mediterranean Regional Office, of course. And that was based on quite an extensive multilateral consultation back at the time. Of course, it does build on some PAHO experience that some of you might be familiar with, called Health as a Bridge for Peace from the 80s, 90s. And it also builds on other existing efforts carried out by different civil society organizations around the world. So this is not absolutely new per se, but as far as WHO is concerned, it does bring new ideas in complement to what was done before through Health as a Bridge for Peace. The most recent development as far as the GHPI is concerned at policy level is the World Health Assembly resolution that was adopted in May 2024 on the GHPI, as you may have heard, but I'll get back to that into more details towards the end. Next slide, please. What is the purpose of the GHPI? What's the aim? It's to strengthen or improve the role of WHO and the health sector as contributors to improving the prospects for peace, directly or indirectly. For example, and that's our main message here, by strengthening programs' conflict sensitivity, or by contributing to peace outcomes where appropriate, and I insist on that, such as, for example, social cohesion. Claver from WHO Cameroon will provide an illustration of that. Dialogue or resilience to the impact of armed violence while empowering communities. All of that in the framework of WHO's mandate and under national ownership. Next slide, please. What do we mean by peace? This is very important. And let me say it quite bluntly. Many of us on this call, and we are more than 300 people, have very different understandings of peace. The peace builders on this call have a definition of peace. The medical doctors have their definition of peace. The anthropologists have a definition of peace, probably. So let's all agree on what we're talking about here, because the GHPI is not trying to become a peace broker or make WHO become a peace broker. So let us clarify what we are referring to. I think it's very important. First, what we call peace, there's two ways of understanding it. Very often we think of peace as the absence of war, the absence of armed violence. And that's what in the peace building sector is being called negative peace. It's just, all right, it's not perfect, but at least there's no war, which is already the most, I think, the most important thing for people's daily life. But of course, it's not sufficient. The underlying causes of injustice, inequalities might just remain unaddressed. And as a result, this is not sustainable absence of war, so to speak. It might just be temporary. True peace or lasting peace is what is being called positive peace. A definition of positive peace says that this is about the presence of the conditions, attitudes, institutions that create and sustain peaceful societies where human rights are being respected, where there is good governance, where there is proper access to justice, a functioning and fair justice system, independent justice system, where socioeconomic rights are being fulfilled, etc., etc. So of course, it is rather an ambition than a reality in many contexts, not to say everywhere, because there's no such thing as a perfect, peaceful society. But that's an important concept to keep in mind. Now, there's another important distinction to keep in mind. It's what we call sometimes peace with a capital P and peace with a small p. Often we also think of peace as being necessarily something political at national level, something that is being negotiated between conflict parties to a conflict, governments, opposition groups. And that's what we call peace with a big P. But there's also peace as social cohesion. That's really sort of set the foundations for political peace to last. That's where resilience and trust are being reinforced in society so that those societies can address conflicts peacefully and constructively. And then, of course, we also here on those two examples, on those two definitions, we also see there's a difference in level. On the one hand, we talk of peace rather at high level, at political level, as I've mentioned. And on the other side, we talk of peace at rather the community level, the local level, in people's everyday lives, so to speak, but also in terms of how the system functions. Now, where does the GHPI sit in all of this? Oh, I'm sorry, Supriya, we would need to go to the next slide. Sorry, everyone, I didn't notice we hadn't changed slide. The GHPI basically mainly addresses positive peace and social cohesion, not so much high-level political processes. And we're not trying to just aim for stopping violence or war, which is a highly complex and highly political process that peacemakers, high-level mediators are meant to do, not us. But we're rather looking at positive peace. So I think those definitions are very important to keep in mind. Next slide, please. So based on all of this, what does the GHPI not seek to do? Let's clarify also all of that. We're not trying to transform WHO in a peace-building agency nor a peacemaking agency. We're not trying to facilitate nor intervene in high-level peace negotiations or to duplicate the mandates and work of other organizations. In fact, rather, we're trying to complement each other within the UN family in order to all try and contribute to sustaining peace and preventing violence through our respective mandates. And here, as some of you might understand, I'm basically referring to the Sustaining Peace agenda. We need to go back to slide number 6. Thank you, what the GHPI is not. We were on the right slide earlier. Yes, next slide again. Thank you. We also don't want to turn healthcare workers into peace builders. It's very important to keep that in mind too, because that's been a fear sometimes within the medical sector. Basically, we're talking of adopting a new approach, a new programming approach at policy and programming level that would require working in partnerships with peace building actors, for example. We're not relying on nurses on the ground, medical doctors on the ground to try and consolidate social cohesion, for example. We're not trying to politicize or securitize healthcare at all, rather the opposite. You'll see later that the health and peace approach that we are putting forward actually helps avoiding that by promoting thorough understanding of conflict and peace dynamics. And I think that helps us being even more neutral and independent. And finally, we're not trying to promote or impose the health and peace approach necessarily outside WHO. If it is adopted, then great, but this is not a normative approach. And usually people expect WHO to set new norms. In this case, let's clarify, it's not something that is becoming sort of a norm. Next slide, please. Very briefly, because, well, that could have been our first slide. Some of you might have wondered when seeing the invitation, why on earth is WHO linking health and peace? So let us explain. Of course, as Altaf referred to, and in fact, that's my next slide, the operational context we're working in has very much shifted. And in fact, the majority of WHO's humanitarian caseload take place in fragile and conflict-affected settings. So we have to be very aware of those contexts and be better equipped with new tools to better work in those settings. But at policy level, there are other good reasons for us to think differently. Of course, WHO's constitution refers to the link between health and peace, But so does the Ottawa Charter for Health Promotion, that refers to peace as sort of a social determinant of health. The Humanitarian Development Peace Nexus from 2016, or Triple Nexus, also refers to conflict sensitivity. It's a key component of it. WHO is, of course, committed to contributing to the sustaining peace agenda that I referred to earlier, but also to the SDGs, and SDG 16 on conflict prevention and sustaining peace is definitely linked to other SDGs, access to basic social services in general, and human rights. And finally, the GHPI is aligned with the values and principles of the localization agenda as well, that was promoted through the Grand Bargain. So that provides a bit of policy background to the Global Health and Peace Initiative. Next slide, please. So that's what I referred to earlier, the shifting operational landscape. Please, next slide. And next again, and again. Now, of course, this initiative sounds like it is most relevant in conflict-affected settings, whether active conflicts, before or after conflict. And it is, of course, our priority. However, the COVID-19 pandemic did highlight the significant impact that poor social cohesion or low levels of trust can have on health outcomes and access to healthcare. This means that the initiative is also highly relevant in countries where social cohesion, trust, or resilience just need to be built or strengthened, which is virtually in all countries to varying degrees. So the initiative is actually relevant in many different sorts of settings. Next slide, please. This is our DG code on the link between health and peace that Altaf referred to earlier, who he has unfortunately had to increasingly refer to in the current context of things. But this is just to show how he thinks of the links between the two, who are definitely bidirectional, which are bidirectional and not just unidirectional. Next slide, please. And before I hand over to my colleague Claver, a few slides on the roadmap of the GHPI, because it's been largely heard about over the last few years. So we want to just give a bit of information on that. So basically in 2022, member states requested the WHO Secretariat to develop a roadmap for the GHPI in a consultative manner. So we held 6 consultations between 22 and 23 and developed 5 different drafts of the roadmap on that basis. The 5th version of the roadmap was put on the table of the World Health Assembly in 2023. And that assembly noted the GHPI roadmap and also requested WHO to report on progress made on the consultative strengthening of this roadmap, considered as a living document. That means we continued consultations to strengthen the roadmap, and that led to not directly led, I'm sorry, in 24, but that's not on this slide. The member states reaffirmed their support to the initiative by adopting a resolution that requests the Secretariat to move on with implementing 4 of the key work streams of the roadmap in particular. I'll go back to that later. We're expected to report to the Assembly in 29 on the status of the roadmap in view of a possible consensual strengthened roadmap. That also means that consultations will continue. We'll also, of course, feed the roadmap development on the basis of learning from country offices' experience and partners' experiences as well. So again, the dialogue is open, and we hope to continue strengthening it with the different stakeholders. Next slide, please. So basically, what the roadmap does in a nutshell is that it provides a transparent framework for WHO to operationalize the GHPI along its 6 work streams. It's available online. You can see the first page of the roadmap here on the screen. You can find it easily online. Next slide, please. What are the work streams of the GHPI, or how do we operationalize the GHPI? So that's described into details in the roadmap, but basically you've got all 6 of them here on the screen. Evidence generation on the links between health and peace, and on the impacts of programming that links health and peace. The development of a strategic framework, I should have started by that. And in fact, the roadmap is a key piece for that. Advocacy and awareness raising on the GHPI. The current webinar series is a milestone activity with that regard. Capacity building on the health and peace approach to programming. And of course, partnership development. That's key because, again, we cannot become peace builders. We do not mean to become peace builders. So if we want to pursue peace outcomes, or if we want to develop conflict analysis, we need to work in partnership with the experts. And finally, and that's the major work stream here, mainstreaming of the health and peace approach. This work stream is pivotal in the pursuit of the initiative's aim of strengthening the role of the health sector and WHO in contributing to peace, of course. So it's the primary work stream under which the GHPI will be operationalized. I think I'll hand over to Claver at this point. I'll skip the next 3 slides and might go back later. So if you can jump over the next 3 slides, Priya, please. And I would like to hand over to next again. Thank you. I will hand over to Dr. Claver Lotsamomo to provide the practical illustration of how we can link health and peace on the ground. So let me introduce Claver. Dr. Lotsamomo works for WHO's Cameroon office. He's actually the project coordinator for the project called Peace Through Health, Peace Building and Violence Reduction in Communities in the Far North through inclusive health and social interventions that recently closed. He is a medical doctor, expert in public health, with almost 10 years professional experience, including 9 at international level. He's got experience in the management and coordination of large-scale public health programs focused on health system strengthening, health promotion, community health, and response to major outbreaks such as Ebola. In addition, Dr. Lotsamomo has experience in implementing and coordinating consortium of multi-partner programs as part of development and emergency programs in insecure and volatile environments, working in West Africa and Guinea, in Central Africa, in different countries, with US-based NGOs and with WHO, and also working with ministries of health, national authorities, local and international partners, of course. Very nice to have you on the call today with us, Claver, and we look forward to hearing your presentation. I may raise the first few questions to you, sorry, because we said let's have a discussion sort of format. So let me start with the first one. Why did WHO Cameroon decide to link its health work with peace objectives? Or how did the context in Northern Cameroon justify using the health and peace approach to programming? Over to you. Thank you.
Okay, Mathilde, good morning. Thank you so much, Mathilde, and thank you for those who are online. Good morning to everyone. Please set my PowerPoint, please. Great. So let me start by briefly sharing with you the background of this case study. So we are in Cameroon. The next slide, please. We are in Cameroon, a country in which 3 of its 10 administrative region has been in the throes of crisis for the past decade. So the Far North region, which lies in the basin, the Lake Chad Basin with Nigeria and Chad as neighbor, is still suffering from incursions by armed terrorist groups. Of the country's 10th region, the Far North has the 2nd largest population, the highest poverty rate, the lowest literacy, and employment rates, and is endemic to cholera and meningitis. Poor access to natural resources, exacerbated by climate change, accentuates community tension and agropastoral conflicts. So those are major contributing cause of conflict in that region where the project has been implemented from December 2021 to December 2023. So as you can see on this schema, at the same time, growing tension between communities and feelings of frustration and isolation have led to the mass recruitment of and exploitation of young people by non-state harm groups. And both, when I said both community pressure and those recruitment lead to health deficit. So now you can just see that when you have community pressure, it could lead to community violence, and the community violence can also lead to health deficit. But in isolation, you can also have the case where, and it was also the case in the far north region, where poor access to health and basic social services, or maybe the low access to health facilities can also lead to health deficit. So, and at the end of the day, we will have a vicious cycle. It is the case on this schema I just we put on which is shown on the screen. So on the right side, I just wanted to share a thoughts I have with you. So working on this project and analyzing some of the facts, I'm more convinced that I'm more convinced than ever that extreme violence, conflict, and war are not different from epidemics or outbreaks in terms of how they are triggered, how they spread, their impact on health, well-being, and the economy of a nation or a society, and so on. Next slide. So just try to, maybe I could be wrong, but just try to think about also. Now, there are a number of reasons why, as Mathilde asks, why a number of reasons why WHO Cameroon and the Ministry of Health have decided to link their health intervention to peace objective in the Far North. The first one I would like to mention is the situation in the Far North, which overlap with the global picture underlying the WHO's Global Health and Peace Initiative, as Mathilde just mentioned. The second one, we were aware that in such a context, the undesirable effects of the conflict will induce indirect morbidity and mortality. But when I said undesirable effect of conflict on healthcare and public health services, you can imagine during the conflict, the farm and food supply system are destroyed, transport, forced displacement, environment, infrastructure are destroyed, and so on. So all this will induce those indirect morbidity and mortality due to the exacerbation of malnutrition, for example, communicable diseases, diarrhea diseases, maternal and infantile affection, mental and behavioral affection, and so on. Now, the third reason is that the president of the Republic of Cameroon has positioned himself as a beggar for world peace, and has committed an institution that supports his country to this cause. The last one, but not the less, is the PBF funding opportunity. All those reasons enable WHO team in Cameroon working closely with the Ministry of Health and International Organization for Migration to design a pilot project linking his health intervention in the Far North region to peace objective. And the aim of the project was to contribute to strengthening the social, political, and institutional condition for effective and sustainable peace in Cameroon by using health intervention as an entry point to supporting national entities and local communities towards promoting social cohesion, dialogue on security issues, and trust between communities and towards national authorities in the Far North region, especially addressing the negative impact of armed groups in the Far North. Slide, next slide, please. Now,
Clever. May,
Yeah.
may I take over and yeah, I would like to then maybe now ask you how the Cameroon project managed to link health with peace outcomes for this project. So I see you've got a slide on the approach, and I think that's when you can nicely explain this to us.
Yeah,
Thank you.
exactly. So I was satisfied on that question. So let's say to better contextualize the health and peace approach, we have considered 4 principles. I think you mentioned some of them before. First of all, we view conflict or collective violence in the same way as deadly outbreaks. I mentioned that. And we know that the only way to eliminate the epidemics or outbreaks impact on the health of community or population is to put an end to the outbreak itself. It's the same with conflict. The only way to eliminate the undesirable effects of conflict on the health and well-being of community is to eliminate the conflict itself. So that was the first principle. The second one, I think you mentioned it when giving a definition of a peace. So peace building process for us is mainly 2 things: avoiding violence plus meeting and promoting basic human needs, including survival needs, well-being needs, human identity needs, and sometimes freedom needs. So thirdly, integrate the fact that peace building and conflict prevention involve people and organization. And fourthly, the respect of the WHO mandate. You focused on that before. So we had, based on all those principles, we had to find a community organization that was made up of community, closer to the community, and which at the same time acted as a relay between the health system and the community. And the ideal structure to play this role was what we call in French COSA, Comité de Santé. In English, we can say Forum for Dialogue and Community Participation in Community Health. So it was the best place to be at the center of this peace triangle and to serve as an operational anchor for the health and peace approach in our context. So drawing on data from our conflict analysis, we identified 3 major areas of intervention that constitute the 3 vertices of our peace triangle. So you can say like the COSA is the one maintaining all those 3 axes. So we have strengthening peace infrastructure. So in this case domain, we have to facilitate the rehabilitation and reintegration of ex-associate or combatants, support implementation of DDR and IDDRS health processes, decolonizing peace through localization, as you mentioned, ensuring strengthening community participation in decisions that affect them. And that's where community-based planning and prioritization was a key. The second vertex was reducing the root causes of conflict by reducing socioeconomic inequalities, strengthening trust, strengthening local governance. And the last one, promoting non-violent dispute resolution. And here we the COSA members just use what they master the most: dialogue and social mobilization. Yes, dialogue and social mobilization to diffuse conflict and prevent their spread. Sorry. So this is really critical when you have to implement or design an intervention on health and peace, or let's say to design a health and peace program. It is really critical to show the good anchor or the good actor who will work or who will implement or who will be like the good relay on the field. So the COSA was the great actor to do that job. And in the Far North region, we just work with the 15 health committees. So 15 COSA, just keep that word in mind. 15 of them, over 289. And in the region, let's say we have eight health district, which bordering Nigeria. So those health district have almost 100 health committees or COSA. So based on the funding we have, we just choose 15 of them to pilot this intervention or approach. So that's what I can give as an answer to the why. Why did we, or how did we link our health intervention and peace objective? So over to you, Mathilde, for the next question, please.
Thank you so much, Clever. I'm very aware of the time, and I think we want to make sure we keep time for the discussion with colleagues on the call. So I don't know if you want to briefly jump on the targeted health and peace outcomes of this project, maybe not going into too many details as you've just described the how of that project, before we address the next question as to what the responses of the partners were, but I can go back to the next questions later on. Do you want to briefly run us through the targeted health and peace outcomes? And maybe can you share the next slide, Supriya? Very briefly,
Next
Clever.
slide, please. Thank you for that question. Yeah. So as you can see, we translated this approach into three objectives or outcomes. So the first was just to increase trust between communities by providing more equitable and improved access to health and other social services. And
okay, let me maybe walk you through the three outcomes very briefly by the time Clever manages to connect again on this call. So as he was describing, the first outcome of that health and peace project was about increasing trust between communities on the ground, including between IDPs and host communities, for example, as well as increasing trust in the authorities by providing more equitable and improved access to health and other social services. This is where the community health dialogue fora was used through inclusive and participatory identification of health needs and health priorities. And based on the needs identified through those community dialogues, they also work towards providing more equitable health services. That included mental health and psychosocial services, physical trauma care, essential health equipment, etc. The second outcome was about improving the ability of the National Disarmament, Demobilization and Reintegration Committee, NDDRC, and other relevant state institutions to design and implement more sustainable and effective DDR interventions. That was mainly delivered by our partner, the Department of Peace Operations, and WHO was poorly, if not involved in that deliverable and that outcome. But it did include one health component, which was about improving local health facilities, including in disarmament and demobilization camps. So, for example, the infirmary was improved, psychosocial assistance was also provided, which really helped building trust between the demobilized former Boko Haram combatants, for example, and the authorities on the ground. And the third outcome was about better preventing youth enrollment and recidivism in armed groups through short-term labor-intensive projects to build, reconstruct, rehabilitate local health facilities, for example, but also in partnership with IOM through capacity building and socioeconomic opportunities for ex-associates and youth at risk in the health sector, in non-health related areas. But as far as the health sector is concerned, that could have included training on disease surveillance, for example, on awareness raising campaigns, etc., etc. All kinds of activities that could help not only the economic reintegration, but also the social reintegration of former combatants by giving them a positive role in their communities, working for health at community level. I don't know if Claver is back online. If so, we can move to the next slide with him and the next questions. Are you back online, Claver? Seems like no. Okay. I can walk you through his slides, but I think he would be a better speaker, of course. Maybe let us continue. Yeah, before we move on the achieved outcomes, maybe we can move back to my presentation on the health and peace approach to programming. Thank you so much, Supriya. Apologies, colleagues, for this technical issue. You all know that happens. I don't know if Claver is in the far north right now or if he's in the capital, but apparently facing some important technical issues. So if you can share slide number 15 of my presentation, if I'm correct, that would be great, Supriya. All right, that's the right one. All right, so you've started to hear about one illustration of what the health and peace approach to programming is about. So before we hear Claver again on the actual achieved health and peace outcomes, let me brief you on the sort of theory of what we call the health and peace approach. It's got three components. Most of them are known to many of you probably. The first one, the first ask of this approach is to make sure that we as WHO do conduct or do use existing peace and conflict analysis to inform our decision making. Of course, we usually conduct risk assessments and of course public health needs assessment. What we're saying here is that we need to add a layer on those in that assessment phase and make sure that any decision is also taking into account peace and conflict dynamics. I'll go back into a bit more details in a few seconds. The second component is called conflict sensitivity. It builds on the analysis that we're using to make sure that we do not do any harm, basically, that we do not affect peace dynamics or peace factors, nor further aggravate conflict factors. And the third step, that's only where possible, that's only where appropriate. It's what we call peace responsiveness. But I've got more details on that in the next few slides. So let me walk you through the next few slides. Next, please. So what is exactly peace and conflict analysis? Here are some of the possible questions, sort of guiding questions for running a peace and conflict analysis. This is, of course, not exhaustive. There is no one-size-fits-all approach to conducting such an analysis. It's going to be shaped by who is conducted it, with what mandate in mind, It depends also on the time and the financial resources available for conducting it, which data is available. But basically, I think this helps the audience here understand what we are talking about. So of course, key questions of peace and conflict analysis are first, what are the root causes of a conflict? Who are the key actors? What are the power relations? Power imbalances certainly need to be clearly understood. What are the main sources of tension? Existing grievances? Are there any marginalization patterns? Which areas are of particular significance in terms of risks, in terms of conflict issues? And very important, how have previous interventions, health interventions in general, from maybe other stakeholders or other UN agencies' interventions in general, affected maybe the conflict dynamics on the ground, and how will this affect future interventions? And with that in mind, we also need to understand what is WHO and the UN's reputation on the ground, or the health sector reputation on the ground, as well as our partners' reputation. That's very important. For example, that played an important role, and sadly a negative role, in what happened in Eastern Congo during the Ebola response, where there was already existing tensions with the authorities, between communities and the authorities, or with the peacekeeping mission that's been staying in that part of the country for several years. So that's to provide you with an overview of what peace and conflict analysis is about. But our main recommendation, of course, to WHO colleagues at country office level is not to necessarily conduct such an analysis by themselves. It takes time, it requires expertise. And what we often advise is to use existing analysis. Resident coordinators office of the UN have some at hand. They can even benefit from peace and development advisors guidance, and just adapt them to WHO's needs and context. This is what we recommend, or working on developing such analysis with peace building partners on the ground, for example. Next slide, please. The second step of the health and peace approach, as mentioned earlier, is what we call conflict sensitivity. Sometimes it's also called peace and conflict sensitivity. Why are we referring to that? Basically, we can't not recognize that any humanitarian development and peace building program in the field can be separated from the peace and conflict context in which they are implemented. They are related. They do not take place in isolation from that context. And in fact, in some cases, our activities, or in all cases, will impact dynamics on the ground, and sometimes in an unintended or indirect way that might be positive or negative. What we want to do is make sure we mitigate any risk of negative impact, and that we increase the possibility for impacts to be positive. And we also want to make sure that we sort of take as much control as possible of our impact. We want to limit unintended negative impacts, in a nutshell. Next slide, please. So basically, the objective, I've just explained it to you, minimizing the risk and manage or mitigate conflict drivers. And what does it take? First, it's the first step I've just mentioned to you, the conflict analysis. So it's basically make sure we have a better understanding of the context. Based on that, number two, we need to analyze the relationship between those activities and the context, and our organizations in the context. It does go back to actually step number one, to conflict and peace analysis. And what's new here is number three, then we adapt our programming, or we adapt the way activities are being delivered. We might even adapt our team composition based on the realities on the ground. So it very much relates to the do no harm principle, conflict sensitivity. Do no harm is very known in the medical sector. It is a medical ethics principle, but as most of you also know, it's also an approach for international cooperation. Next slide, please. So how, practically speaking, can conflict-sensitive programming take place? here are some possible entry points. I've already referred to perceptions on the ground. I think it's very important that we make sure in our communication, in the way we interact with communities on the ground, that we're perceived as neutral and that we maintain trust. The selection of beneficiaries or service users is also very important. We need to make sure we are not biased and that we include all groups in society, that we do not replicate marginalization patterns, for example, and ensure equitable access to those services. Team composition and attitudes, as I've mentioned, may also matter. Language, gender might be very important factors, but most importantly, respectful behavior, inclusive practices, sensitivity to cultural practices also are very important for the teams to be accepted on the ground. And of course, all of that can only be carefully thought through by engaging with community actors. That's, I think, very obvious, but it's important to stress that. Conflict sensitivity does require engagement with local stakeholders, and so does the analysis. Resource procurement and delivery, in some cases, without, of course, that to be planned, needless to say it, it may happen that the resources delivered may feed the war economy or cause tensions when they are being delivered. We need to make sure this is being prevented. And a last example of possible entry points for conflict-sensitive programming is inclusive communication and engagement. I think that's a valid point throughout the program cycle anyway. Next slide, please. The third step of the health and peace approach, or the third component, is what we call peace responsiveness. It's a concept actually that was developed by Interpeace, and it's one of our partners working towards enforcing WHO's contribution to peace outcomes. And the definition of peace responsiveness in our case is designing and implementing health programs that not only address immediate health needs, but actively or more actively seek to contribute to peace outcomes, such as those we've already referred to earlier, mainly at community level. So mainly looking at social cohesion, building confidence, building trust, etc. Again, this is peace responsiveness is not the key message of the Global Health and Peace Initiative, but it's something we promote where appropriate. The decision of designing peace responsive programming is to be done at country level with governments and based on risk assessment. The requirements for this is, of course, to collaborate with other stakeholders with peace building expertise. Here again, as we did in Cameroon, we collaborated with IOM to deliver some of the peace building activities. In Guinea-Bissau, we're working with Interpeace to deliver peace building activities and their local partners. In other settings with UNICEF, UNDP, who also have extensive peace building expertise. So that's important to keep in mind. Next, please. Let me continue with the possible peace outcomes and activities of health interventions. I apologize, we're trying to discuss whether our colleague Claver was on the call again, and how we address his slides. If not, hopefully we'll find him again very soon online, but yeah. So yes, possible peace outcomes. So these are basically examples of peace responsive programming. I think it's very important because while conflict sensitivity is a key message that sort of everybody understands and agree with, peace responsiveness is sometimes more and misperceived or misunderstood or just new to people working in the health sector. So here are some examples. Keeping in mind, every context is different and every context requires different peace outcomes to be targeted and different activities, of course. But for example, health programs can contribute to reducing exclusion and strengthening trust between populations and the authorities. This can be done through different activities. Here are some examples listed on the right, through ensuring universal and equitable access to healthcare. Hi, Clever, glad to see you again. I'll finish my presentation and hand back to you if that's fine with you. I'm almost done. Opening dialogue between populations and authorities over health needs and services, and that's what was done in Cameroon. Or inclusive and participatory policymaking, like they did in Tunisia, for example, the government did. Reinforcing social cohesion between and within communities is also another peace outcome that health programs can try and contribute to through community dialogue and participatory health governance again, or for example, by providing mental health and psychosocial support to support stability and reconciliation. That type of activity, by the way, also helps preventing violence repetition, other type of peace outcome, and supporting reconciliation processes at community level, like has been extensively done in Rwanda, for example. Other possible activities for preventing violence and supporting reconciliation includes designing health activities for groups at risk of violence, like was done in Cameroon. I've given that example earlier to support their socioeconomic reintegration. Or like was done in Colombia, supporting the reintegration of health personnel from demobilized armed groups into the health system, for example. That was done in 2016 after a peace agreement. Next slide, please. And here you've got other examples of outcomes and activities, such as facilitating rapprochement and building confidence between parties to a conflict through, for example, joint training of health personnel across the conflict line. It's been done by many, many NGOs across the world, actually. Cross-line dialogue and technical cooperation, such as disease surveillance and response across the conflict line as well, as an example. Another type of peace outcome, but I would say negative peace outcome rather than positive peace outcome, which is what we really try to contribute to, is facilitating temporary humanitarian ceasefires, such as the days of tranquility that have sometimes facilitated humanitarian access for polio vaccination campaigns, for example. We've seen that in Latin America in the past. In Gaza, we've seen similar example a lot more recently. And another level of possible peace outcome is fostering cooperation and improving relations between countries. This is not the focus of the GHPI, but it's just being mentioned here because it is a possible peace outcome per se. That's basically what is being referred to as health diplomacy. And of course, this refers to interstate collaboration, but also high-level dialogue and negotiations over global health policies. Next slide. I'll finish here. Oh, yeah, sorry, I had a different slide on my version. Yes, that's fine. Where are we heading? Basically, based on the recently adopted resolution by the World Health Assembly that was in May this year, the member states requested us to move on with the four sets of work streams, the four sets of activities that you see here on screen. Evidence gathering, communication and awareness raising, capacity building, dialogue, and partnership. So we are collecting all suggestions related to the initiative. Your feedback is most welcome. But also, as I've said earlier, we will continue strengthening the roadmap as requested by member states. So there will be a 6th version at some point in the future. This does not mean that countries, WHO country offices are not implementing or mainstreaming the health and peace approach in the meantime. Mainstreaming might be a strong word, but implementing this approach, as was done in Cameroon, through a dedicated project. And in fact, 3 country offices are currently implementing such projects in Guinea-Bissau, for example, in Haiti, in Liberia, with funding from the Peace Building Fund. So it's dedicated funding for dedicated health and peace projects, from which we are very much learning and from which we are going to be able to continue strengthening the GHPR roadmap. Other countries have also experienced or piloted this approach in Burkina Faso, in Somalia, and Sri Lanka. And on this note, I'll hand over to our colleague Claver to wrap up his presentation. Claver, I would like to advise you to maybe wrap up the presentation in maybe 5 minutes. So if you want to guide us as to which slide you would like us to show, I think maybe we can, if you want to share the key messages, the good practices and lessons learned that emerged from this project on maybe slide 11, Supriya. I think it would be helpful to wrap up the conversation, since we want to have a few minutes left for the discussion. If you can go on to slides 11, 12, Supriya. So that's
slide 11,
over
please.
to you, Clever.
Please. So I think when she will share the slide with all the participants, so the participant will have a chance to see the achievement. I'm just going to skip that part.
Next slide, Supriya, please.
Next slide. Next slide. Okay, so these are some lessons learned from the project. Sorry, so please come back to the previous slide, please. Okay, thank you. So I just wanted to share this lesson learned from the project. So during the implementation, what we notice is that when the choice of the geographical and administrative level or health pyramid of intervention is really critical. As we mentioned, the health actor or health anchor for the implementation of the approach is decisive. So geographically, what we advise is to work at a local level, or rural level. And the reason is the higher vital risk and the high concentration of need. And the health actor we can advise you is the health system dialogue structure or community health workers platform at the community level, depending on the structure in your country. And the reason we have so many reasons: good community-based trust of the population, and they are good channel for decolonizing HNP, health and peace intervention. But they also master, as I mentioned, the peace building tools, which is dialogue and mobilization, community mobilization. What we also learned is that when you train them in humanitarian principle, it is a key of success, because they use some of the actors or members on the field. When there is an opportunity, what they do is to direct it to their family members, and sometimes it can also increase the tension, community tension. So it is important to train them on humanitarian laws, and maybe you develop an SOP that they will sign by knowing their responsibility and engagement in the project. So the second lesson is about partnership. Partnership with local administration, local organization, and international organization. So those who peace building is their key area of exercise in. So that was the case. That's why we work with IOM, International Organization of Migration, in this project, and with local NGOs to implement, and local administration to implement the project. The last one is when we notice that image you can see, a health worker administrating vaccine. So during the outreach immunization campaign, COSA members used to sensitize communities about peace issues or conflict issues, and the result was really good or great. And that's why we said advancing health outcomes during like vaccine equity, while contributing to social cohesion and reducing marginalization, is also something important. So At this point, next slide, please. So there is a link. Through this link, you will have an opportunity to learn a lot about this project, what we were not able to mention. For example, the perception of the COSA before the start of the project regarding WHO involvement in peace issues, and also the involvement of administrative authorities and socioeconomic activities through cooperatives as a means of reducing marginalization. The next slide, please. So I'm going to conclude by sharing the thoughts of the PBF focal point at the Fano Governor's office. He said the project was well received, especially considering the vulnerable situation of the Fano region, which has been affected by ongoing insecurity and conflict. The project utilized a health platform not only to improve health outcomes, but also to foster peace and social cohesion among diverse community groups. So the local administration was really a great partner for the success of this project. So thank you so much, and we are really sorry for what's happened. My computer, I don't know what's happened. Sorry.
That happens, Clever. No worries. Unfortunately, we are still dependent on technology for online calls. Thank you so much. That was very much appreciated. I also see people in the chat thanking you and congratulating you for this very informative presentation. I would like to open the floor for a few questions. Unfortunately, time is very limited. I think we can maybe take at least 2 questions to start, and if we can, we'll open the floor for more. And before people raise their hands or write a question in the chat, I would like to respond to one question that we identified in the chat, which was, in how far mainstreaming plans will be influenced or changed by evidence generation. At present, there is very limited evidence on effects of this approach. So how will this influence timing and content of the roadmap? Thanks so much for the question. It's very relevant. So let us clarify. As I've mentioned earlier, the roadmap is considered a living document, and it won't be finalized anytime soon. In fact, the next deadline, so to speak, for the roadmap consolidation, if not finalization, I wouldn't call it like that, is 2029, because that's when it's going to be put on the table of the World Health Assembly again. So between now and 29, I think more projects will have taken place within WHO, but also outside WHO. And in fact, several partner organizations are on this call, and they are also actively working using a similar approach, linking health and peace-building objectives, for example. We can also learn from them. So I think between now and 29, we will have learned a lot more on the impacts, on the links, and hopefully the roadmap will be strengthened, the approach will be strengthened by that time, and it will influence any mainstreaming effort. But this doesn't mean that it will stop in 29. We will continue learning, and we will continue improving as we go. Monitoring, evaluation, and learning is very important for us. It is part of our strategic priorities under evidence generation. And we will engage with stakeholders from the peace sector, from the health sector, primarily on how to measure, how to monitor and evaluate programs that link health and peace, as we've described, and learn from that. I hope that answers the question. Do we have other questions in the chat or? Supriya, have you identified any other question?
Yeah, there are a number of questions in the Q&A box. There are about 20 questions.
Yeah, sorry, indeed. I was looking at the webinar chat mainly. Okay, I've seen a question on the countries that have already begun to implement health and peace programs. So I can briefly repeat that list. I think it's important for people based in those countries to be aware of those. So currently, there are ongoing projects in Guinea-Bissau, in Haiti, and in Liberia. In Liberia, I think it's led by UNFPA, but WHO, UNICEF, and another agency are partnering on that. Other projects that are closed, but that did health and peace programming, as we call it, include Cameroon, Burkina Faso, Somalia, and Sri Lanka. And in Somalia and Sri Lanka, it was mainly focused on mental health and psychosocial support. I hope that helps. I'm trying to see, gosh, there are so many questions. I think I see a question about whether WHO would like or is considering doing similar programs like in Cameroon for Myanmar. We don't know yet. This is a decision for the Myanmar country office to consider, of course. It is a very complex setting. And what was done in Cameroon might not be applicable in Myanmar, of course. But as I said earlier, those decisions are being made by country offices and in discussion with the national governments. The Myanmar situation is a very particular one, so I would not be able to answer on behalf of the country office. I would like to also address a question from Emro. What sustainability strategies can be implemented to ensure long-term success of the GHPI outcomes? That's a very good question. I think we are still very much trying to learn from what's happening on the ground. But basically, a major entry point for sustainability is localization. As you know, localization is one of WHO's objective as well. We, in fact, are about to publish WHO's localization strategy. And just as for emergency response in general, and for development and peace building in general, we need to rely increasingly on local actors to pursue the objectives we're trying to achieve. So I think that's one part of the answer to your question, Lamia. Thanks for the question. I'd like to give the floor to Claver again and raise another question that was put in the chat. Claver, can you share with us what were some of the implementation challenges that you faced in Cameroon? I think it was part of your presentation, but since it had to be shortened, over to you.
Okay, Martin. Thank you for that question. First of all, let us mention little evidence in the literature on best practices in health and peace intervention around the world. Secondly, we can say monitoring and evaluation and learning framework. So there was a lack of health and peace generic indicators. Yeah, but it was also a learning opportunity for us. We can also mention low participation of women within the community, low availability of qualified human resources at local level during the conflict, particularly in the health sector, a very low availability of financial resources to support the initiative. I can also mention a real need of, let's say, the needs are enormous, to be honest. The needs are enormous. So that's what I can say, because when the implementation was going on, the feedback we received was, we are just targeting 15 health COSA, but there are so many we also need the same help What are you going to do? Even for participants. So it was really hectic for us to manage those kind of feedback. So that's what I can say in terms of difficulties or challenges. Thank you.
Thank you so much, Claver. I wish we had more time to address many of your questions that were raised in the chat, but I'm afraid we'll have to close to respect everybody's schedule today. If you can kindly share my second to last slide, Kanika. We'll bring this to a close. So first, let me tell you, we will try and address the questions that were raised today in the Q&A box. Thank you so much for raising so many interesting questions. As we said to you earlier, this is only the first webinar of a long series. We are planning to hold one webinar every 2 months. So quite regularly, as long as we find relevance. For now, we're considering maybe over 2 years. Let's see. And there's going to be many other topics coming up. The next topic, and that's going to take place in early December, maybe on the 5th, to be confirmed, is going to be it's going to be a discussion with the commissioners of the Lancet Commission on Peaceful Societies through Health Equity and Gender Equality. Basically, they are going to share the key findings of that commission, and we are going to have the privilege of having Valerie Percival talking with us. She was basically the pen holder of that report, and another speaker whose name still needs to be confirmed, but highly experienced profiles. We will soon also have sessions dedicated to integrating MHPSS, mental health and psychosocial support, and peace building. And different NGOs are going to be also invited to share their experience working on that. We will make sure there's a strong practical component each time. We'll also make sure there's more time for discussion. Today was the idea was really to provide both an overview, but to also give you a sort of case study. So it was a bit dense, but we will make sure we keep more time for discussion. So let me thank you at this point. Thank you very much. And I would like to also warmly thank Supriya for hosting the webinar series of the GHPI through EPI-WIN. And again, thanking Claver and the country representative in Cameroon for having contributed to the GHPI and contributed to this first webinar today with us. Thank you to all participants. See you in 2 months, hopefully probably on December 5. Over to you, Supriya.
Thank you very much, Mathilde. And thank you to all the speakers, first of all to Mathilde for moderating this, putting this whole webinar together. Thank you also to Frédérique for her support in this webinar, and to the rest of the GHPI team. Thank you to Dr. Altaf Musani for his support and his guidance for this. And finally, last but not least, to all the participants who joined today, who made time to join today and take active part in this very, very important issue. Thank you to Claver, who, in spite of technical difficulties, still made gave a very insightful presentation about what Cameroon has done, which is an inspiration, I'm sure, for many other countries in future. And thank you finally to the EPI-WIN team. I would just, before we leave, a quick Slido. Matilda, would you still be interested in this Slido from the participants?
Yes, please, sure.
So we have a few questions on Slido. I've put the link also on the chat, so and we will leave it open so you can continue to put in your responses to all the questions. We didn't have time to go through all of them today, but please give your responses. We'd love to hear from you and hear your thoughts. And Before we end, I'd just like to say that our next EPI-WIN webinar is on Monday, 14th October. It will be on infection prevention and control for healthcare workers in the setting of MPOX. We look forward to seeing you then. It's a drastically different subject from today's, but that's the beauty of EPI-WIN. You get a wide range of topics that you can take part in. Thank you once again, and see you soon. You will get all the presentations and the Slido link and the recording. All registrants will get that, so don't worry, but it's great to have you here, and thank you, and bye-bye.